Okay, we'll go ahead and get started. Again, I'd like to say welcome. If you guys were at the Airway Symposium this past weekend, wow, what an exciting time this is. We actually have an exciting lineup for you guys tonight as well. Well, I'm going to start telling you a little bit about our CEO and President, Leslie Stephens. She's actually going to be on our platform tonight, which we're really excited about. A little bit about Leslie. She's a mother of three. Her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. I'm going to switch. There we go. There's a silent epidemic, as you know, affecting 9 out of 10 children, and this epidemic manifests itself in a variety of symptoms that can be easily overlooked, misdiagnosed, and most unfortunately left untreated. So it's critical that children are evaluated for sleep and breathing habits. And so Leslie is not only our fearless leader, she actually lectures and she trains all over the world. She'll be in Rome soon. I don't think that there is a question in reference to the subject of pediatric sleep breathing, airway health, and HealthyStart's connection that she cannot answer. And when you have the backing of a company like HealthyStart Ortho-Tain, you have 51 plus years, over 4 million cases, and tons of research to back you. Leslie's mission is to educate both parents and oral physicians to ensure children a lifetime of health, happiness, and success. We also have Dr. Jill Ombrello with us this evening, which we're very excited about. If you guys were at the Airway Symposium, you were lucky enough to hear her speak. We absolutely adore Dr. Jill. And that's actually what her patients lovingly call her, Dr. Jill, and we do as well. She's one of our premier providers. She's an expert trainer. She's an international lecturer. She actually spoke, as you know, at the Children's Airway Summit on children's airway health. She travels around the world to share and educate other doctors on pediatric sleep disordered breathing and HealthyStart's non-surgical, non-pharmaceutical therapy to treat children with sleep-related breathing disorders. Dr. Jill is a third-generation dentist. She herself was a HealthyStart patient and success story. And as she states, we are saving children one child at a time to let them become the very best versions of themselves. She completed her BS in exercise science at St. Louis University and her DDS at the University of Texas at Houston Dental Branch. She is a frequent volunteer providing public health dentistry care in underserved areas of Texas, as well as rural villages in Alaska. She donates time and dental services to the Genesis Women's Shelter to help the victims of domestic abuse and restore their dental health. She also provides treatment to elderly patients who reside in nursing homes and helps educate their care teams and families. She and her husband are proud parents to 4 beautiful children. And as the very last line of her About Me on her Central Dentist website, she also loves Beyonce. So I am going to actually hand the screen, the microphone, the floor over to Dr. Jill.
Hey, Susie, thank you so much, and thank you for the nice introduction. I'm excited to be here tonight. I don't know how you guys are doing. I'm actually at the office here this evening talking to you guys. I went home and picked up ballet, did dinner, and am now back at the office to talk to you guys. So I'm so glad that you're making the choice to now become involved. I'm so glad Brandy Burgess has already asked a question. Are we saying that 90% of children have sleep disorders or sleep apnea? Hey, great question. And this is something that I talked about at the ADA and something I talk about quite often. There was a study that was done with 501 children, and I'm going to reference it here in my presentation, but let's bring it up now since you asked the question, and you were the first one at the top of the hour, so thanks for asking that. This study that analyzed about 501 children to be exact, found that 9 out of 10 children exhibited an outward sign of symptom that's commonly associated with sleep disordered breathing. So while we're not saying 9 out of 10 children have sleep disordered breathing or sleep apnea, what we're saying is actually many of these children exhibit these outward signs and symptoms of sleep disordered breathing that are commonly being treated with a more pharmaceutical or invasive therapy by another doctor. So really the take-home message of this 9 out of 10 kids is this is an epidemic. This is something that's affecting children all over the world, all over the country, and they're in your practice, they're in your carpools, they're coming for play dates, they know your children, they are your children. And so it's much more prevalent than we might think. So hopefully I answered your question, and let's dive in. I'm going to show you a few other things here that'll hopefully pique your interest. I'm going to share my screen here. Hold on as I become smarter than my computer, which is easier said than done. Here we go. So if you guys, we had a great weekend at the ADA this weekend. I have to tell you, there were some really super smart people, Harvard, Stanford, all kinds of researchers were there talking about all kinds of things. But kind of the underlying theme or the feedback that I got from a lot of the doctors and a lot of my friends that attended were, hey, this is great information. I feel very informed. But you know, now what? Now what do we do? How do I take this back Monday and talk to my patients and tell the mom of the child of the 8-year-old bedwetter? Or how do I talk to the mom of the 4-year-old teeth grinder? What do I actually say to them without getting them all riled up? I need a solution. And so that's what I really want to talk about tonight. What do you do? What could you have done starting Monday morning? What did I do when I walked into the office today and started treating my patients? And I'm in a general dentistry practice. I'm not a pediatric dentist. And so I'm talking about this with my kiddos that I see already, but I'm also talking about this with the adults that I see. You know, we actually had a patient in today. She was 94 years old. And when I was talking to her, about her great grandkids and how they sleep and how they do. And luckily great grandma is going to push her grandkids into bringing her great grandkids in to be assessed. So this conversation can happen in a lot of different ways with a lot of different people. I want to start off with one of my heroes, Mr. Rogers. I know it sounds cheesy. I grew up with Mr. Rogers, but one thing that Fred Rogers says that I hold very dear to me is anyone who does anything to help a child in his life is a hero to me. So I want to applaud your efforts for showing interest and getting together here at 8 o'clock on a Wednesday. I know it's not the easiest time to get together, but I think that you're here because you're like me and you want to help these kids. You recognize there's a problem and you want to help the kids. So what can we do? That brings me to another one of my heroes. We have Dr. Bergerson here, who invented the solution to how we can help these children. All the appliance techniques that I'm going to talk about tonight were all invented by Dr. Bergerson. What's really cool is he invented a lot of these 50 years ago. He's been testing in mom patients, and he's still continually inventing and still innovating and finding solutions for patients. I had the privilege of spending time with Dr. Bergerson at the ADA meeting this weekend, and I was telling him some of the issues I'm having with patients and how these appliances are helping and areas that we still need help. And you know what? Dr. Bergerson smiled and said, you know what, Jill, I'm going to work on that and I'll get back to you. So I know he is somewhere working on his invention and really figuring out what else we can do. He's a board certified orthodontist. And truly his commitment is to improve the well-being of patients. His vision that he had 50 years ago to create an appliance that helps children not only correct their oral habits, but then guide their teeth into the proper position to potentially avoid having to wear traditional braces, has been the vision of the company for 50 years and is something that Leslie Stevens continues with the vision of the company. And it's really a very exciting thing to be a part of. And I'm so happy that you guys are becoming part of the Healthy Start family and can continue this vision. Dr. Bergerson's one of the most prolific inventors in dentistry today, and he has over 500 patents. So he has taught growth and development at Northwestern. He actually skipped out on part of the lecture this weekend to spend time in the library at Northwestern because he wanted to look up a thesis paper he'd been thinking about, which is insanely genius. But I didn't go to the library. I don't know about you guys, but he was there for us. So whoever was there this weekend, I talked a lot about, and we heard a lot about proper oral habits, the proper way to swallow, the proper way to breathe, and that will essentially help grow and develop the mandible and the maxilla to be where it's supposed to be. Now I'm going to show you some cases here in a minute. But let's get real. How do you do that? You're going to look at a 2-year-old and say, okay, kid, breathe different. All right, 8-year-old, swallow different. Absolutely not. These are autonomic things that happen without even thinking about them. Yes, perhaps this child can go to myofunctional therapy or speech therapy and practice in that session proper tongue position in a static position, perhaps in a dynamic position, but that's a very short session. And then they're sent off on their own. Mom's given the list of exercises they need to do, but you know, in most cases, moms aren't trained to recognize if the tongue is in the proper position or not. So it's a very stressful situation to be in. What's really cool about the Healthy Start Habit Corrector is when we recognize these poor oral habits that all the research is pointing to saying is stunting the growth and development and altering the course of these kids, ultimately the development of their airway. What's really cool is you can use one of these Healthy Start Habit Correctors, have the child wear it at night only while they sleep, and we see all of these symptoms improve and eventually resolve. Parents love it because really what we have to do is find a time in their bedtime routine where we can introduce the appliance. and that's it. So, you know, when we talk to parents and we create a customized compliance plan, now recognizing that your child has an anterior tongue thrust or is a mouth breather, et cetera, we can now introduce this appliance and say, listen, your child, instead of taking in appropriate air through his nose, is taking in emergency air through their mouth. So we're going to give you a rescue appliance with this habit corrector. Your child, because they have such strong habits, I'd like for them to wear this appliance maybe 15, 20 minutes during the day just to get used to it. Because I tell you, if you introduce this right at bedtime, the kid's like, I don't want it. I'm not going to bed. Mom and dad are going to quit. That was my kid voice. It sounded kind of annoying tonight. Sorry, but that's what my kids sounded like tonight when I was trying to put them to bed. But when we, if they wear it for 15 or 20 minutes or even 5-10 minutes, depending on how old they are, and they get used to this appliance, it's much easier for them to start wearing it at bedtime. We have to manage parents' expectations and say, hey, listen, guys, your child is 7 years old, for example, and has been a mouth breather for 7 years. We're not going to correct this overnight. This is a habit. We'll take little steps each day, and eventually that habit will improve and resolve. So maybe they wear it for an hour the first night they put it in. Awesome. Let's celebrate. That was an hour of their sleep with that they were breathing appropriately through their nose. Well, yeah, it fell out the other 9 hours. That's okay. Let's try again tomorrow. Maybe the next night they get an hour and 5 minutes. Great. Eventually, that child's body will adjust to where they're wearing it all the way through the night. I think it's really important to realize that these are not really super quick results that happen overnight. If you want quick, give me right now, go have surgery, go take a bunch of drugs. That will give you something really quick. And I think, you know, we all have it in common that we're avoiding the quick fixes. We're avoiding the surgery and the pharmaceutical intervention because we want something that's more natural, that goes with the natural growth and development of the child. So again, habit correctors vary on size based on how big the child is, meaning how large their upper and lower jaws are. These are all things, the specifics about each appliance are things that you'll learn in the certification weekends or on the online webinars. So I encourage you guys to sign up to do that so you can learn more about it. I'm going to talk about all the appliances, but of course I'm going to give you an overview. When you sign up for a certification to become a HealthyStart provider, we spend a lot of time together. Usually 2 days we spend talking about this. I'll also tell you, 2 days, it is a lot of time. We learn a lot of info doing that. But what's really great about HealthyStart is with each case, you can submit a case review. So you submit your diagnostic records, the panoramic x-rays, some digital photos, you send that in, and then you get an expert review that comes back that tells you which appliance to use, how to use it, and what to truly expect with treatment. You can also then use that as a sounding board as you work your first few cases and say, hey, is this normal? Is this how it's supposed to go? And you have somebody, for lack of a better term, holding your hand all the way through the process. Now, we know, and we heard this all weekend at the ADA, and I think this is what all the literature, these are all the buzzwords, this is what all the, actually the myofunctional Facebook groups, and even some of the mom groups that I'm in on Facebook that are talking about. Narrow jaws, improper tongue position, mouth breathing, affecting jaw relationships. Those are our big 4 key words that everyone's kind of talking about. Here's the cool thing. The habit corrector, this first appliance that I was talking about, addresses all of those. It expands the arches. It puts the tongue in the right position. It reestablishes nasal breathing, and it puts the jaws in a favorable position. So it all happens at the same time, and it all happens while the child sleeps at night. It's really incredible. So, I included some of these tonight because I wanted to talk about this. How do we start talking about this tomorrow? You guys are listening to me tonight. You're going to be so excited. You're not going to sleep tonight. You're can't wait for your first patient tomorrow that you can talk to this about, right? Hopefully that's the feedback we'll get. But this is what you're going to look like, or this is what you're going to look at. We know a kid with an anterior open bite. We know that's a dental nightmare, right? We know that's a big deal. This kid is headed for trouble. And I tell my parents this in my practice all the time, 100%, I want your child to have ideal overbite, ideal overjet, and I don't use those terms with parents. I say, I want your top teeth to overlap your bottom teeth just a little bit. So when your child smiles, we see all their teeth. We don't want to see any of their gums. We want to see their top teeth and their bottom teeth. We want this beautiful smile. But I want this beautiful aesthetic smile. One, because I want your child to be pretty, since they're our patient, we want them to be pretty, but also because we know that if all of this has formed appropriately, I know what's going on back here with the airway is also very healthy, which is what I care about even more. So let's take a look at this anterior open bite. We know that's a nightmare. The parents probably know that's a nightmare. My kids' teeth don't touch. I make hamburgers and my kid leaves the lettuce behind when they eat the cheeseburger, for sure. But we know, and I show this to parents, that when they have that anterior open bite, now this is not the same patients, but we're just talking theoretically here, so hang with me. When we're looking at this anterior open bite of this child, we can see what that does with an open bite, how that compromises the airway. So by pushing the mandible backwards. So I know that if I can, one, break the habit that's causing the anterior open bite, with which this kiddo is probably an anterior tongue thruster, as well as a thumb sucker or finger sucker or whatever. We know this kid sucks. And I'll just say that, this kid sucks. What are we going to do about it? We have got to replace that sucking habit with something else. You can put the nail polish on there. You can tie them up. I was actually on Amazon the other night just searching to see what moms are looking for to stop the sucking habit. And they look like little medieval torture devices. All these things you can strap on and hold back. So I found it's been very effective to just replace that sucking habit with the habit corrector. So they get that same sucking cessation, but it's it's appropriate tongue position, and it's promoting that downward forward growth. So it makes it better. So when you're talking to your parents, of course you want to talk to them about beautiful, healthy teeth and how we want these beautiful, healthy smiles. But what's more important is what's happening behind these smiles, what's happening behind these teeth. And that has to do with their airway. So we know that once they have proper oral habits and once they're functioning the way they're supposed to, they will grow and develop the way they're supposed to, and they won't end up with smiles like this or teeth like this. Same thing here. Here's a tongue thrust we could talk about and look at. And if any of you guys want any of these pictures, reach out to me. I will provide all of them. Reach out to Healthy Start. If you want to put these in your office for educational purposes, let us know. We will give these to you so you can show parents so they understand what you're talking about. Not everybody has a CBCT in their office, and that is totally normal. It's absolutely not the standard of care to have one of those. But I'll tell you what, it makes it so much easier to talk to parents when I have a picture of an airway that is very narrow and when I have a well-developed airway. It just really helps in the education. So until you get one on your own and you want to borrow some of those images, have at it. Just let us know. These are all things that we're looking at. We can see these flared upward incisors from a sucking habit. This is also a thumb or finger sucking. A constricted maxillary arch. So we see these top teeth are smaller than the bottom arch. We know that if everything is supposed to grow downward and forward, if there's some sort of restrictive force that's causing things to go inward and up, like a CPAP, like a sucking habit, all kinds of things. We have to eliminate that habit before we move on. So let's cruise through these sometimes. I have this slide here just kind of as a placeholder to remind you guys that we are absolutely the experts in oral habits and growth and development of the head and neck. You may not feel like an expert. You may feel like you're in over your head. If you're like me, there's some days that I'm like, there is so much information. I feel like I'm trying to take a little sip out of a fire hose. Someone's pointing a fire hose at me and I'm just like, trying to take a sip. It's really, really hard. So let me take this opportunity to remind you, you are the experts. We are the experts in this realm. And if we don't act that way, if we don't demand that type of authority, our parents are going to go other places and try to find other information. And I do this frequently. I go out, I Dr. Google, I look at what are other moms looking for. And there is so much misinformation out there that they're getting. And that's what they're using. That's the type of information that they're using to make choices for their kids. So I know you're already inspired to be here, which is why you're here at 8 o'clock on a Wednesday night. But let me just say this, ad nauseum, that this is our duty to really talk to these kids and talk to these parents, because the amount of misinformation out there is just absolutely atrocious. And it's actually really, really sad. When you Google on how to stop thumb sucking, there's everything from authority and demanding, using peer pressure, hot sauce. There's all kinds of just horrible, horrible things that you could do. Good. So again, I'm going to encourage you as you're looking at these children, you're going to look at their faces, you're going to look at their features, you're going to look at their measurements. And it doesn't have to be well, I'll say this, as dentists, we work in millimeters all day long. We actually work in quarter millimeters, right? We want the margin of the crown to be absolutely perfect. We want our restorative preps to be absolutely perfect. And for sure, that's why we became dentists. We're probably all very type A and proud of it. I think that's great. You have to kind of switch gears a little bit when you start looking at these kids and look at it from kind of a global perspective. When you look at this child here, I don't need to know how many more millimeters the lower third of the face is shorter than the rest. When I first look at this child, I see that, you know what? His mandible is short. He has a little double chin there. It is underdeveloped. So look at it more from a global sense. Let's look at, I'm sorry, we're going to go this way. A child with a rolled lower lip, a kid that's going to suck their lower lip. Notice their habits. Notice their habits before you bring them into the room, before you bring them into the operatory and they know they're being stared at. I encourage you, and I do this with all my patients, no matter how busy I get, with all kids, especially if they're new, I go out to the waiting room. And if they're playing in our playroom or they're doing homework or they're reading a book, I get down on their level. So a lot of times I'm on my knees. Sometimes I'm sitting Indian style with them. We call it crisscross applesauce in our office. And you sit down and you really talk to them and you know, yes, it takes 5 minutes, but we're looking at facial symmetry, we're evaluating speech, we're seeing how they breathe, how they swallow, how they interact, their personalities. We're gathering so much information. I actually get more information about that kid in the waiting room in about 5 minutes, just talking about their day at school and, hey, what are you reading or what homework do you have? What's your favorite movie? I get more information in that 5 minutes than I get actually back in my operatory with my mirror and my probe when I'm measuring everything. So I would encourage you to change that. And even just taking that time, parents really appreciate you taking the time to make their child feel comfortable. It helps the culture of your office. So it's just a little bit more comfortable and more fun. And it makes the conversation when you bring this up to the parent much easier. So I make a priority, no matter how busy I am, I take a deep breath. I don't take the stress of whatever's happening in another operatory. I take it up front. I leave that there and I go up front, take a deep breath and really get on the kid's level and talk to them and gather a lot of this information. So I think a lot of us understand childhood breathing issues. Just to touch on it a little bit, we talked about it like crazy last week at the ADA, but just to touch on it a little bit, you know, breathing issues, we obviously want the child to breathe in through their nose and have proper nasal breathing. We heard at a very high level last weekend, what all the research states. Here's what I tell parents. I talked a little bit about this at the ADA, but I'd love to go into more detail here. We know that when a child breathes, we want them to breathe in through their nose, filter, humidify, purify that air, get it ready to go into the lungs so that the lungs can then distribute the oxygen and all the appropriate air to the brain and to the heart. The brain is functioning properly, the heart is functioning properly and beating at a normal rhythm. If there's enough oxygen, again, guys, this is simple science. I hope there's not a pulmonologist in this meeting because they would beat me up about this, but this is, again, how we explain this to the parents. So if there's enough oxygen after the brain and the lungs get it, then we're going to send it to the endocrine system. So we have proper hormonal balance, proper growth hormone release. If there's enough oxygen, it goes to our digestive system. And so we're going to have a good immune system because we know so much of our immune system's in our digestive system. We're going to have proper digestion, so we're not going to have constipated little kids. If there's enough oxygen left, we're going to go to the urinary system so that we're able to, not wet the bed at night. And then if there's enough oxygen, we're going to go into that deep level of sleep that's called REM sleep so that we can actually get growth and repair. If there's not enough oxygen, if it's not the proper amount of oxygen, our body can't function the way it's supposed to. Again, that's super oversimplified. I talked about that with the medical doctor last weekend, and he's like, well, what is the, he was like a robot. Well, what is the, biochemical inhibitor? I'm like, who cares? I mean, that's important, and go do your research on it and figure it out. But as a mom, we don't need to know the biochemical inhibitor of this hormone during this cycle. What I need to know is, why is my kid wet in the bed at night when I've restricted his fluid starting at 3 o'clock in the afternoon? So this is an explanation that kind of works with that regard. So when I tell them, hey, your child actually isn't breathing properly and isn't taking in the proper oxygen for their body to function right. So if we can get them breathing right, we can get them functioning right, they'll start to grow the way that they're supposed to. Now your child takes air in, for a mouth breather, for example, through their mouth. We're forcing their tonsils and their adenoids to work hard and do a job that they're not supposed to do. So when that air goes into their lungs are thinking, what is this? What is this air? We get an underlying inflammatory response, which can manifest as allergies or eczema or all different kinds of inflammatory responses throughout the body. And there's not enough oxygen to go around. So something's not going to work right. Parents understand that. They look at their kids and they're like, yeah, he's a mouth breather all the time. When we're in the car, watching TV, at school, look at him right now. That little brat's over there mouth breathing right now. Not really, they don't call them brats. Sometimes they do, but anyway, no judgment. Look at that kid, he's mouth breathing right now. This is crazy. So that makes sense to them. When they understand, hey, our goal is to have their body function properly. Most moms, whether they are, from a Medicaid office or they're from an affluent family, whether they have a brother who's an orthodontist, regardless what it is, I honestly think that there's an underlying commonality amongst parents, moms especially, but dads too. We've had some incredible dads in our office this week, but parents really want the best option for their children. They really want the easiest, most comprehensive, holistic approach to having their child be the best version of themselves. Given all the misinformation that's out there, it is a struggle as a parent to decide what is the best thing for them, what is the best way to go. And so by giving them that simple science explanation and telling them, we simply want your child to function the way they were designed. They're perfect just the way they are. We just have to have them function we need them all cylinders going, everything functioning properly. Okay, what do we do? Here's what we do. And that's when I start talking about the HealthyStart Habit Corrector. That's when I introduce this appliance that is going to help correct their habits. It's going to have some myofunctional therapy in there. So we're going to have, have their muscles functioning properly for a lifetime. If we can work really hard on your child right now for the next few months, again, manage parents' expectations, but depending on the severity of their symptoms, some of these habits resolve in as quickly as 30 days. Some habits can take 4 or 5 months, again, depending on the severity of how many habits they have. But if we can work really hard for, 1 to 4 or 5 months to resolve these habits and correct them, that'll set your child up to be successful for the rest of his life. And then, by the way, guess what? Now that we have them growing the way that they're supposed to, let's go ahead and finish it. And let's go ahead and guide the teeth into the proper position so that they're stabilized with those good habits. And parents say, well, what do you mean? Because I had braces and my other kids have braces. What does that mean? And that's when I introduce the other appliances in the series of appliances. Now, there are different appliances depending on the child's age and depending on the dentition that's present. So a child that has, a younger child, the 2 to 5-year-old in a primary dentition, we really focus on habit correction. That's what we're focused on. That's what we want to cement. That's what we want to improve, moving forward. Once children start losing teeth, so 5, 6, and we see that mandibular central incisor lost and the permanent tooth starts to erupt, what's your option there? Well, I give the parents the option. I let them choose. I say there's 2 different philosophies. There's the traditional orthodontic philosophy where what they do is they attach an external metal force to the teeth. And what they're looking to do with that is to guide the teeth, or they wait typically until the teeth have erupted, and the periodontal ligament fibers, and the ligament fibers are just like the ligaments in your elbow and your knee that attach these teeth. There's hundreds of thousands per tooth. And with traditional orthodontics, typically what they're doing, again in simple science terms, we are tightening those braces, we're tearing the fibers and moving the teeth. And then we go in and retighten them, tear the fibers and move the teeth. How long you're in traditional braces is how many adjustments you need, how much movement we need on those teeth, and then how long it takes for fiber regeneration. Now, again, with traditional orthodontics, when we've moved those fibers have a tendency to go back to where they were originally, which during that conversation, the parent usually says, oh yeah, I didn't wear my retainer. Look at my teeth. I'm like, okay, that's a separate conversation. But yes, so you know exactly firsthand how that works. So that's one philosophy. Again, that is oversimplified. There's a lot of orthodontists doing different things with expansion and all of that, but typically with traditional braces, that's the philosophy you're signing up for. Another option that you have is that we can, we've talked about the habits that your child has. We've recognized ways that their growth and development is being inhibited, or it's not ideal. So we correct those habits. And once they're corrected, rather than waiting, what if we then guide those teeth, the erupting teeth, into the proper position? We put them in the correct position, and then the fibers attach to those teeth and mature and hold that tooth in the right position. And the good news is we've corrected the habits, then caused the teeth to possibly be malaligned. So now all the habits are corrected. We've guided the teeth into the proper position. The fibers have attached the teeth, and the kid's done by 12-ish years old, 28 teeth in the correct position with proper oral habits. And then they don't need long-term retention. Where's that tooth going to go? We've corrected the habits that might push the tooth somewhere. The fiber's attached where it's supposed to be, and you're good to go. Which option sounds better for your family? Now, I'll tell you, I've had a couple of parents say, well, I had braces, my kid's getting them too. Great. Have fun with that. Good luck with that. Traditional orthodontics in my zip code here where I am is 3 times the fee that I fee out for my HealthyStart patients. But that's fine if that's what you want. This isn't the right fit. We philosophically don't align. I'll tell you, that happens few and far between. And the few times that it has happened, those families have actually returned back to our office to become HealthyStart patients because they realize, hey, with gluing metal forces on the teeth, there's a lot of issues with oral hygiene, there's a lot of checkups, there's a lot of appointments, etc. So that doesn't always sound as great as it seems in the beginning. But hey, if you want to go try it, go for it. We always have this option here for you. It is based on their growth and development, and every day your child is growing and developing, and we're losing that. But hey, you make your choice, whatever you think is best. So those series of appliances we spend a great deal of time on during the certification weekend and during the online webinar, talking about exactly what they can do and which appliance to use. I will tell you, I have a chart here that shows you the different ranges. There's a HealthyStart Kids, preteen, and teen and adult. Of course, the more growth and development that is remaining, so in a younger child with more growth and development, the more that we can accommodate, the more that we can change. So millimeters of crowding in a 5-year-old. That's incredible. Of course, that decreases as the child gets older because there's less growth and development. So while everyone this weekend was really focused on the poor oral habits and why these kids aren't sleeping well and what those symptoms look like, I wanted to kind of stand up and scream, hey, I got it. The research is there. We get it. Now what? Okay, we've got to correct the habits. I get it. Now what? What else can we do? And so what's really exciting, and I'm glad that you guys are joining me tonight to hear that, yes, we correct the habits and then we follow the kid. We go all the way through to then align them so they have a proper TMJ joint position, because we've advanced the mandible, we've put the condylar head where it's supposed to go, the disc is where it's supposed to go, there's no popping and clicking, we've expanded the dental arches so there's room for all the teeth so that they're aligned, we've corrected the habits, and we see that child all the way through. There was a few dentists that I talked to this weekend that wanted to talk about their own children. And so a couple of them were class 3 kids that were younger and have a pseudo class 3, maybe one even had a skeletal class 3. This has just kind of been popping up more and more. I was in a Facebook group of mommy dentists. If anybody here is in that group, nice to see you. But there was a post in the mommy dentist group on Facebook that said, hey, my daughter has a class 3, what do I do? And I just kind of hid and watched because I wanted to see what they say. Sometimes when you type a comment, then people comment on your comment and you lose sight of what you're even talking about. But I wanted to see what people say. There was an orthodontist who said, wait and have surgery when she's 18. One say there was a whole list of appliances. I didn't recognize even one of their names of them, but that was an option. One was a chin strap headgear, 24 hours a day. One was just at night. There was a lot of different treatment potential that they were talking about, but none of them really sounded realistic, nor did they sound very fun to use. And people also didn't have before and after pictures. So I actually spoke up and I said, the HealthyStart Class 3 habit corrector is an awesome option. That's going to promote not only the full development of the mandible, but we're also going to focus on the maxillary development. So we're going to help those pseudo class 3s. We're going to use the natural pressures of the tongue, which is a super strong muscle. I learned that today in some of my crown preps. I just couldn't get that tongue out of the way. It reminded me how strong the tongue is. But we're going to use a child's tongue and wearing this appliance to apply pressure to the anterior portion of the appliance to really promote the growth of the maxilla and correct that pseudo class 3, which is really exciting. I've seen every pseudo class 3 that I've treated correct in as quickly as 2 to 3 months. Parents are ecstatic. That puts them back where they're supposed to be and on the track where they're supposed to be. I had a true skeletal class 3 whose orthodontist just said, let's wait, let's wait, let's wait. Their uncle was an oral surgeon. He said, let's wait, let's wait. I said, hey, you know what? This isn't going to correct it totally, but it can improve it. So let's see what we can do. We put a class 3 in that child, and we actually improved that skeletal class 3 and we put the incisors in an end-to-end position. Now that kid, luckily, he may not have to be a surgical patient. He could be, but he doesn't have to be. His orthodontist can align his teeth and correct it so that he doesn't have to be a surgical patient. I don't know how many of you all have seen a patient that's had oral maxillar surgery to correct a class 3. It's pretty hairy. The recovery is pretty hairy, and I'd like to avoid that at any cost, especially if it were one of my kids or one of my friends' kids, for sure. So there are adjuncts. There's also these appliances also exist here in the HealthyStart system to address some of these other issues. We talked a lot about the sleep disordered breathing screening questionnaire. I was a part of a roundtable on Thursday with a group of doctors talking about the screening tools, talking about what we could do to really look at these kids and how we can talk about these kids. And I was really, really impressed because with myself, I will say, I was really impressed with myself because this is the questionnaire that I use. This is the screening tool that I use with my patients. And I have to say, in that room of very talented doctors, I feel very confident I had the best screening tool. This is the best screening tool. There were other doctors that did a snore plus, for example. So they would ask the mom, does your kid snore? No. Okay, they're fine. Moving on. Well, did you ask mom what it means to snore? Do they snore at all? Do they snore infrequently? Do they snore 1 or 2 nights a week? That all counts. Do they have labor difficulty breathing at night? Snoring no longer has to be, old fat grandpa in a recliner watching football. Like that, yes, that is also snoring, but it can just be this audible snoring. So I was super excited and proud to have this screening form there and feel confident in saying, hey, HealthyStart has the best screening form and is looking at all the symptoms and the degree of symptoms so that we're not leaving a child behind. We're actually really addressing those. Here's, this is, kind of a heavy slide here with a lot of information. We've covered a lot of it, but I included this just so that you guys could know there are several different sizes. There's several different indications why you would use them, whether there's an open bite or not an open bite. Again, in the online webinar certification program or in the in-person certification, you learn the intricacies of all these appliances. And when to use which with which child. And then you can also, kind of have peace of mind knowing with every case you do send in a case review. And so you'll have a certified doctor who's very experienced walk you through that and give you advice on that. Here are some pictures of the eruptive appliances here that are guiding the teeth into the position that I was talking about. We have the C series, the IG series, and the G series, and then the for the adult dentition, there's several different models. You know what? Parents, when they first see them, kids love them. We have demos in our office. HealthyStart gives us a demo tree, which is just kind of like a stand with all the appliances. We have that out. We let kids touch them. First thing they want to do is throw them in their mouth, and we're like, sorry, that was our dog's appliance. You can't wear it, just to be silly. But, kids want to put it in. Parents are sometimes concerned about compliance. And I'll tell you, yeah, with other things, you glue them in, you put them in, they have no option but to wear them. But with these, we've found, even with the 5 to the 7-year-old, if we explain to them, hey, this is what it's for, this is how it's going to help you. And whether that explanation gets into the nitty gritty of, hey, this is going to help, hey, 9-year-old, this is going to help you breathe better so that you don't wet the bed so you can have your slumber party with your friends, whether it's that type of explanation, or if it's an explanation to a 5-year-old and explaining, hey, did you know that, well, here in Dallas, we see the Dallas Cowboys. Did you know that all the Dallas Cowboys wear these appliances at night so they can run faster than all of their friends? Who's your best friend at school? Oh, my best friend's Tommy. Okay, I want you to wear this. Don't tell Tommy you're wearing it. You're going to sleep better. And I want you to race Tommy at school every day till you beat him. And then you come tell me, okay, we got this. So whether that conversation, and I actually had that conversation with the little boy today, and he's going to race Tommy tomorrow. We'll see how he goes after he wears his appliance. But that conversation can vary based on the age of the kid. You just have to figure out what's going to speak to this kid, what's going to motivate them. If you are out of touch with kids, that's not your thing, no problem. Find someone on your team who's really good at it. An assistant who maybe has some kids in this age and is speaking the language and knows what they're watching on TV, knows what the movies are in the theater, knows about the squishy balls. If you don't know what the squishy ball is, find someone in your office who knows what the squishy ball is. It's the most popular thing amongst kids right now. So they'll be able to talk their language. Great. Let's look at a few cases, because one thing I wanted to yell at the ADA was, one, okay, thanks for scaring me. Thanks for telling me all these things that could happen. Now what do I do? And then I also wanted to yell at them, hey, don't tell me, show me. Show me what you're doing. You're talking about how you're going to improve, the growth of the maxilla and the mandible. Great. Show me how you're doing that in your practice every day. And then I'll follow you and I will listen to everything you have to say. So here we go. I'm going to show you. Some of these cases are mine, some of them are not, and I've credited the doctor here. So here's a great ideal HealthyStart case that we have here. We have, permanent teeth just starting to erupt. You can tell from this case just looking at them, it's going to be crowded. The overbite and overjet's going to be there. Parents decided they didn't want to do it, which I find that hard to believe, because Dr. Marino, who's a brilliant doctor out in California, there's no way he didn't convince these parents, but we'll play along. Patients didn't want to do it. What happened? Developed into a deep bite. I think this little girl had an anterior tongue thrust, so we see a diastema. We really see a cathedral arch of the maxilla, so it's more pointed in the front rather than a horseshoe where it's nice and round and developed. We see crowding of those mandibular anteriors. We see these laterals coming in that are kind of a nightmare. I mean, this is par for the course. What's a different outcome for that kid? That kid says yes to HealthyStart. What's a different outcome? Here we have a kid, very similar, anterior tongue thrust, a well-developed arch, but malaligned teeth, crooked teeth. He's going to wear that. About a year later, look at that kid, ideal overbite, overjet, guiding those teeth into the proper position. He's still not perfect. This isn't a perfect smile yet, but you know what? It's been a year. The traditional orthodontist would have done any better. If you notice here, he's cavity free, so he's still maintaining his oral hygiene. Things are looking good. Let's go forward again. Look at this kid here. It's a beautiful case, beautiful arch that you can see in the left middle page here. Thirds of his face are well developed. Great profile picture. Mandibular anteriors are all in line where they're supposed to be. Midline's intact. It's beautiful. What's great, again, we know this kid has a beautiful smile. How old is this kiddo? When he started, he was 7 years old. We know he has a beautiful smile. Great, but what's going on underneath that? We know if that mandible is forward and we have a minimal overbite and overjet, this kid has a well-developed airway. We know from the sleep disorder breathing questionnaire that his parents filled out that he's symptom-free. He's doing really, really good. He went from a 4, which is pronounced poor ability in school, to a 1 at his follow-up. So he's really improved. The parent actually said the teacher says he is caught up to grade level. That's incredible. This is probably a really struggling kid. Kid was snoring up to almost every single night, having labored, difficult breathing. Now he doesn't have audible breathing when he sleeps. That's huge. Excessive sweating while he's sleeping, and that is resolved. So I can't tell you enough how important the sleep disorder breathing questionnaire is. Yeah, I take a good-looking kid like this with a beautiful smile every single day in my practice, and they can go out and smile and be great walking little billboards for Payson Dental or Orthodontics here in this photo who did this case. But what's even more fun is we know that this dental solution really solved a medical problem. This kid, who was snoring, struggling in school, stopping breathing at night, wetting the bed, having restless sleep, grinding his teeth, is now sleeping peacefully, calmly, and not snoring. I'll tell you what, that's amazing. Absolutely amazing. Okay, good. In the interest of time, I'm going to cruise through some of these. Here's another photo here, courtesy of Dr. Arango. We have the initial photo here. This is very common. So maybe we don't catch them right as that first permanent tooth starts to erupt. We catch them later on when there's less growth and development. No problem, we can still intervene. This is an orthodontic nightmare here in this initial photo. Clearly lots of habits that we can address, and the progress of that's not even a finished case on the lower right, looks really good, and is a nice, healthy child. Here's a photo of the appliance in place and what it looks for. Again, we'll spend a lot of time during the certification weekend talking about how to fit the appliances, making sure they are worn appropriately, how the children wear them. But I think it's also important just to note on this photo how easy it is for them to wear, how unobtrusive it is for them to wear, and actually how comfortable. As soon as they begin to wear it, they get accustomed to it, they get used to it. That's commonly a question that parents ask me, well, what if they won't wear it? And I give this really simple analogy. As an adult, kids, they do things because it feels good, right? That's kind of where they are. They don't have the emotional baggage surrounding it. So it gets them in trouble sometimes when they get older, but when they're younger, if it makes them feel good, they do it. So adults, for example, I'll give myself as an example. When I eat a cheeseburger, I feel terrible. I don't have energy. I feel, heavy, slowed down, blah. I don't do it. But what do? I eat the cheeseburger because it tastes good, right? It's terrible. Even though I know it's not going to make me feel good, I still do it. Let's go back to the kid, okay? Same example. The kid sleeps and doesn't really feel any better when they sleep. Of course they don't want to nap. Of course they don't want to lay down. You give them an appliance that helps their body function the way it's supposed to, and they wake up feeling rested. They wake up feeling faster. They can run faster. They can jump higher. They can keep up with their friends. You better believe they're going to do that. They don't care what it is if it's going to make them feel that way. They don't have that weird, I don't know, maybe I have emotional baggage about a cheeseburger. Who knows? That's a separate webinar. We can diagnose that. But I'll tell you, these kids just really respond well to, I feel good when I wear this, so I'm going to continue to wear it. So much so, we actually saw a handful of kids here at the end of the summer who were going away to college, who are HealthyStart patients in our practice. And I said, okay, you're 18, give it up. You don't need your appliance anymore. I've been trying to take it away from you for 4 or 5 years. You're finished. And they said, no, I have to take it to college. I just love it. I can't sleep without it. I'm like, okay, great. Take it with you, but when you lose it, you're done. So kids actually, they like to wear it, and they don't want to give it back. Good. I know I have a few questions here, so I'm going to leave plenty of time to answer that. I'm just going to throw up as we talk these live lecture dates that are coming up. There's one pretty quickly here in California. I'll be out there and would love to get to see anybody who wants to come. We have some other lectures. Dr. Burton is actually the inventor of the appliance, is actually going to be in Chicago on September 23rd and 24th, which is an absolute incredible experience. We'll be in Orlando. We'll be in Toronto. There's more on the schedule. If it doesn't work for you to travel, hey, I totally get that. I have 4 kids and soccer and school, and I get all of that. There's an awesome option with these, with the online webinar that happens every Friday. That has been a huge hit with a lot of doctors who are unable to travel, and it's a great experience as well to get certified. So I'm going to leave you with this last quote. I told you Fred Rogers is my hero. I told you Dr. Bergson's my hero. My other hero, another one of my heroes is Tony Robbins. So I'm just going to leave you with this. This quote: what we can or cannot do, what we consider possible or impossible, is rarely a function of our true ability. It's more likely a function of our beliefs about who we are. Now, I take this, I just got goosebumps reading that. I love Tony Robbins, and here's why. If I only did things based on my ability, I wouldn't do great things, guys. I have to be honest with you. I'm a very average doctor, very average dentist, but I'll tell you what, my beliefs about who I am, I truly believe that I can help these children become the best versions of themselves. I truly believe that it is my duty as a dentist, as a mom, as a human being with this knowledge to share it with as many people as I possibly can. It is my belief that who I am is to share this knowledge, motivate people so that they can go out there and also share it and also help these kids. So remember that as you get started, this is something brand new. If you haven't done it before, it was brand new to all of us, but at one time. So recognize that if now that you know this, you can't unknow it, which isn't a great quote. No one's going to quote me on that. But now that you know this, now that you know as a dentist, you have the power to help these children become the best versions of themselves. Believe that about yourself. Go out there and get it done. Talk to these kids. And what's great is you have the support of HealthyStart to help walk you through it and provide, hold your hand or provide advice or input at any stage of the game. So follow what Tony Robbins says and get out there, and we can really just help these kiddos. So if you have any questions, I'm happy to answer those now. Thank you so much for joining us tonight. And I really look forward to seeing you guys either in person or on a webinar or via email or any way that I can help you guys, let me know.
Thank you so much, Dr. Dill. There are actually a few questions, and if you don't mind, I'll go ahead and tell you the first one now. So the first question is, can you give us the best advice? Basically, back when you started and began treating pediatric sleep, what's the best advice that you can give in reference to how you got started in treating children?
Yeah, for sure. So I actually started I'm a fourth generation dentist, and I started a practice from scratch in 2008, which was the year of not great economical things. So I think I was a little crazy doing that, but it's what I wanted to do. So how I really built the practice, and I'm a fee-for-service practice, how I really built that was starting the conversation, because people don't know what they don't know. And the first, cheapest, easiest thing to do is introduce the HealthyStart sleep disorder breathing questionnaire to every patient. Every kid 18 and under fills it out about themselves. Every person 18 and older takes one and fills it out about a child in their life that they know. We hand it out, we huddle in the morning with our team, and we say, who can we ask for referrals? Who can we have this conversation with? And like I said today, I had the great grandmother in, and I said, hey, you know what? I know she has 3 great grandkids that are pre-K age. Let's ask her about them and see how they're sleeping, see how they're doing. And we actually gave her the sleep disorder breathing questionnaires to take home to give to her grandchild to evaluate as the parent. And we give stamped, self-addressed stamped envelopes so they can mail it back to us for a free evaluation. And typically no one mails them back ever, but they call for an appointment. They'll fill it out and then call and say, you know what, I filled this out and I was questioning it. So that sleep disorder breathing questionnaire is the best thing to start with. I also would go into schools and do complimentary evaluations of children, evaluating their habits. I'd fill out the screening forms, send them home with the children, and welcome the parents to call me so we could discuss. That was great. And at first when I was trying to get this going, I unfortunately had to kind of operate a little bit on their schedule. So I offered some evening hours to just do a Zoom call, just like we're doing tonight, where we could join together for 15 minutes from 8 to 8:15 or from 12 to 12:15 during lunch. And I really gave away a lot of information, and it really tried to educate a lot of parents and talk about it, knowing if I just really educate, if I let people know what's going on, they will come and they will want more and they will want to help their kids. And so when I first started, I treated, my team's kids for free. So they started talking about it. I offered free consultations. I introduced that sleep disorder breathing questionnaire, and then just kind of got more advanced with technology and more advanced in my diagnostics as things went along.
Awesome. Thank you so much. So I wanted to mention, there's a couple of other questions, but really quickly before I ask those questions, I just wanted to mention, if everyone can hang tight, because I am going to talk a little bit about our digital platform at the end. And really what I want to help you guys understand is how you can actually get started with a couple of cases. So we're going to offer you some free cases to get rolling. So anyway, so I'll get to that at the end though. So a question from Dr. Taylor. He says, or he asks rather, where does a potential tethered tongue evaluation fit into the algorithm?
Hey, great question. Because I don't know if you were at the ADA webinar or ADA symposium last weekend, Dr. Taylor, but that was a really kind of overlooked concept that no one really addressed. And I think it's a huge piece of this puzzle. So I'll tell you, I was a newbie with tethered tongues and tongue ties and frenectomy. I was a little scared of them, quite honestly, to begin with. And so in the beginning, I didn't really address it at all. In the last probably 5 to 6 years, I've started to address them and release the tongue, and worked with an oral or a myofunctional therapist with a list of exercises that I would give to the parents for them to use after we release the tongues, because we do want the tongue to have full mobility for proper speech, proper swallow, etc. And I realized this weekend, I learned that giving the parent a list of exercises to have their child do after a frenectomy is inadequate and is actually below the standard of care. So I was happy to learn that, a little embarrassed, but happy to learn that, and now know that I need a myofunctional therapist who they can to refer to, that they can actually continue those exercises. So 100%, it's a huge piece of the puzzle. I think what's really exciting is we're including myofunctional therapists in the conversation to help guide us in the proper exercises to help after the tongues have been released. I will say, though, there's been a huge push on soft tissue lasers. That soft tissue laser rep brought me free lunch every month for like 3 years before I purchased one. They're really out there. They're really in our faces about these lasers. And unfortunately, a lot of people are releasing tongues and doing such extreme frenectomies that they're actually causing tongue dysfunction as a result of that. So I think that this is an area that needs a lot more education. I tend to be more conservative than just to go in and use my laser and release the tongue. But I think that there's going to be a lot of information that comes out of the ADA from this on when it's indicated and when it's not, and then exactly what to do and who to refer to afterwards. So thanks for bringing that up. It was overlooked in the ADA, and I failed to mention it tonight. So thank you for bringing that up.
Awesome, thank you. Okay, so another question: do you refer kids? Do you refer kids to ENTs for sleep studies, or do you typically base your diagnosis upon the sleep questionnaire that's provided?
Yeah, that's a great question too. So, I used to think that PSGs in hospital were like the go-to. That's what we're going to do. And then I had a good friend that I sent, that I referred to a board certified sleep doc for the in-hospital. And she's like, it was horrible. I think she said exactly, I don't sleep well in the Four Seasons, let alone in a sleep clinic with my son, and my husband was home with the other kids. It was terrible. Don't ever ask me to do that again. So while that is the gold standard and that's what they want us to do, I'm not sure how realistic it is. It's also very expensive. So here's what I do. As dentists in the state of Texas, I technically cannot diagnose sleep apnea. I can recognize the outward signs and symptoms of sleep disordered breathing and treat those as it relates to the growth and development of the head and neck. So that's a fine line. It's a bit of semantics, but go with me on this. So I can absolutely refer to a sleep doc to get that taken care of. But what I found is most effective is I'm basing it on that questionnaire. I did purchase some home sleep tests that I use in office. I have a Knox T3 and a ResMed, but those are very expensive. And looking back, I'm not sure I would buy them again, to be quite honest with you. Here's the thing, you get a PSG, and I'm talking about the kids in the middle of the road. There's always the outliers, the really super sick kids with severe sleep apnea, and 100% they need to be referred and managed by a board certified sleep doc, 100%. There's the really healthy kids who have no sleep issues, so those are easy. I'm talking about this middle of the road kids kind of in the middle. And for those children, I've sent them off for a sleep test, formal sleep test. I've done the home sleep test, and then I've compared that with their Fitbit or their VivoFit Junior that they wear at night that measures their sleep disturbance. Of course, the in-hospital sleep test is so exact, and the AHI or the disturbances are so exact. The home sleep test is pretty close, but maybe it's off a few. We still know there's a problem though. So do we really care? And I, when we talk about, we give the parents the option, I say, hey, it's close enough. Like I don't approach anything in dentistry with the concept of it's close enough, but with home sleep tests, it's close enough. If they don't want to do a home sleep test, that's also tough. They have to wear a belt, a nasal cannula. They have to wear a little O2 measure on their finger. So that's also not feasible. So put a Fitbit on them and see that measures their sleep. And I wear a Fitbit Versa. It's not expensive. I mean, it's kind of expensive, but it's not the most expensive thing when we're talking about home sleep test evaluation. And it shows my disturbances in sleep. So that's enough for the parents to see it. And then as they wear the appliances, to see it decrease. So it kind of depends on how fancy you want to get. But when you first start off, just use the sleep disorder breathing questionnaire, order a couple Fitbits off of Amazon, and that is enough to screen and enough to kind of recognize what's going on. If it's something really severe, make the appropriate referral. If not, treat with the HealthyStart habit corrector and watch how they kind of resolve and improve with wearing of the appliance.
Thank you. Okay, so Dr. Chisler is asking, would you recommend using CBCT imaging or ECG tests for diagnostic purposes?
Yeah, so great question. That was kind of a heated topic at the roundtable as well. You know, I use 3D CBCT to measure the airway, to measure the volume of airway. I got a lot of heat about that at the roundtable because they were saying that's in a standing position, and so it doesn't actually mimic what it looks like when you sleep. And my comeback was, you're right, but if a child is sleeping laying down, do you agree that the airway would be even more compromised than when they're standing up? Well, yes. So I said, okay, so best case scenario is the imaging that I'm getting with the 3D CBCT and the volume. That's the best volume that the child would have, correct? Yes. So we know if that's compromised, we know it's going to be even worse when they sleep. So I tell you that because I don't think, I don't think there's an answer to that. I think it comes down to personal preference. I think it comes down to when the scientific research doesn't tell us exactly what we're supposed to be doing, we use our experience and our expert opinions to form what works best. And so for me, I prefer the CBCT. That's what I have in my office, and that's what I'm using. But I really think that after this first ADA symposium, there will be future ones. I really think that there will be a guideline and there will be parameters set on which ones are the best diagnostic tools. So I don't think that I'm the authority on the subject. I could argue, you know, anecdotally, this is what I do. This is what I'm doing in my office. Of course, I think what I'm doing is the best. That's why I'm doing it. If I thought that I wasn't doing something that was good, obviously I wouldn't do it. So I don't think I don't have a definitive opinion on that, nor am I the authority. I just kind of know what I'm doing in office with me and what works here with me. I would say when you're screening and evaluating children, if you think that it's a severe case, make the referral. If not, use diagnostic tools, which can also help educate the parent and help monitor their children continuously as they wear the appliance to make sure things are improving and resolving.
That's awesome. Thank you. Okay, so another question.
Answer. Sorry, Susie.
No, that was a great answer, actually. So that was very good. How would you recommend proceeding with a case in which a patient had been recommended to wait on tonsils and adenoids by an ENT? How do you advise the parents that proceeding with oral appliance therapy is beneficial?
Awesome. Anonymous attendee that asked that, are you an ENT that you're wanting to see what we're saying about you behind your back? Just kidding. You know, this is actually a really common, situation. A lot of ENTs look at a child's tonsils as surgical or non-surgical. So if they're surgical, they're obstructive, they have a Mallampati score of, 3 or greater, whatever their standards are. They have a standard of this is surgical, this is non-surgical. I explain to the parents that I live in the gray area. So if they're surgical, yeah, they're surgical. If they're non-surgical, but maybe they're enlarged, maybe they're inflamed. So the habits are causing the inflammation. I just had a kid in Milan. He was in yesterday. He has his tonsils and adenoids removed a year ago. But guess what? He's a huge mouth breather. What's a huge mouth breather? He has a very strong mouth breathing habit, I'll say that, and that hasn't been corrected in a year. So he has inflammation of his adenoids and his tonsillar tissue again. His dad was mad. I mean, he had no idea. What do you mean we have to do it again? Well, no. If it's surgical and it's obstructing the airway and they have these habits, you know, and the parents don't want to have the surgery, I don't blame them. Tonsils and adenoid surgery, the recovery from that is a beat down. I mean, it is hard to see a little kiddo in pain, and it is a good 2-week recovery. I get it. So let's do this. Let's change the habits. Let's see if we can establish nasal breathing. Let's see if we can have the tonsils and adenoids calm down, not have to work so hard. And maybe that level of inflammation will decrease, and then they'll become a non-surgical patient. but manage the parents' expectations and say, hey, listen, the doctor, the ENT kind of puts your kids in two categories, surgical or non-surgical. I live in this area of gray. So if it's non-surgical, that's great. Let's try really hard with the habit corrector and see if your child can correct their habits in 2 to 3 months. Let's evaluate the tonsillar size, swelling by looking in your child's mouth every month for the next 4 or 5 months, and let's see if it doesn't decrease. I'll tell you, in my son, Vinny, he was a mouth breather. He had a lot of different oral habits. He was not a surgical patient, according to the ENT, but man, his tonsils were huge. We spent about 4 months correcting his habits, and then all of a sudden his tonsils decreased in size, and it was clear as day he wasn't a surgical patient. So as a mom, I was ecstatic to avoid that type of surgery, but always just kind of set it up that they may possibly need surgery down the road if their habits haven't been corrected. And then I'd also say about the ENT, if the ENT is not on board with what you're doing or doesn't share your philosophy and isn't, if you guys don't have your core values aligned, look for another ENT to refer to. Easy for me to say here in Dallas, ENTs are all over the place, so it's easy to, not easy, but I have options. If you're in a smaller town and there's maybe one ENT, that's not an option. I recognize that. So maybe having an opportunity to have a sit down and share ideas so they know what you're up to might be really beneficial so that you don't have an ENT that you're fighting against, which kind of that scenario kind of sounded like you'd be butting heads with them a little bit.
Awesome, thank you. Okay, so last question is, how are you determining which kids are severe and need to be referred to an ENT? Do you give every child a home sleep test?
Yeah, great question. I do not give every child a home sleep test. I give every child the sleep disorder breathing questionnaire that I've talked about quite a bit tonight, and I submit the case. And if that child is severe, so we're talking 4s and 5s on that questionnaire when they're filling it out. If you haven't looked over that questionnaire, I encourage you to spend a couple of minutes and you'll know what I mean by 4s and 5s. That's ranking the severity of the symptoms. If you're seeing a child that is has interrupted or disruptive breaths while they're sleeping, they're snoring, really that stoppage of breathing is what kind of freaks me out a little bit as a dentist and as a mom. Now, some parents don't really know what that means, and some parents have kind of subjective opinions of sleep because of how they sleep or their bed partner. So what I do is I just ask parents, I'm very generous with my cell phone or your email, whatever you want to do. I ask them just to take a video of their child sleeping at night and send it to me. I say, don't turn on any lights, but just so that I can hear it. My husband thinks it's creepy when I'm looking at these videos at night, like watching children sleep, which it is kind of creepy, but I'm listening to how they're breathing. I'm listening, is there interruption in their sleep? So I would advise, home sleep tests are expensive. And like I said, they're kind of hard to do sometimes on kiddos. I would advise you to have them fill out that sleep disorder breathing questionnaire. If you're questioning based on the severity of symptoms that the parents are reporting, if you're questioning whether it's severe or not, ask the parent to take a brief 2-minute video that night, sneak in the room after the child's in bed, take a video and send it to you so that you can just kind of hear how they're breathing. And if you hear interruptions or you hear some really disruptive snoring, then consider a referral.
Great. Thank you so much, Dr. Jill. So I was going to bring Leslie into the conversation as well. And Leslie, I was wondering if you could talk a little bit about what the response was this weekend from the ADA and what we're hoping to accomplish.
Oh, it was an amazing, amazing weekend. I don't know how many of you were attending. I think everybody walked away with the feeling, I have like-minded colleagues. I have people that I can refer to, talk to. I feel more confident. I realize the direction I want to. And I think people are just truly excited to investigate and start pursuing this avenue of treatment. As I said at the meeting, pinch me, tell me I'm not dreaming. It has been a long road to start the education, but I think we're here. We're here. And everyone I talked to was so positive. Jill, you are truly amazing. We applaud you. You are so down to earth. You just make everything fun, laughable, but most important, you give so much valuable information. So my goal, my dream is to continue this conversation. The weekend was great, but if the conversation ends, we've wasted that time. So the importance is to continue talking to each other, continue this conversation. And as I said in my letters that hopefully you received, I'm planning on making a huge impact on the amount of kids that are affected. There are 40 million children right now, tonight, that are affected by sleep and breathing disorders. And if we can put a dent in that number, more power to us. And if we can make that dent by March of the next meeting, Healthy Start will donate 400 cases to children in need. I always say no child should be left untreated, and I will put my money, I will put our cases, I will put our energy behind that statement and make sure
Yay, that's awesome.
that kids are being addressed. And I can't tell you, we have research projects on the forefront. We have organizations, the AAPD reached out to us. They have 20,000 children nationwide that they would like us to look at. The new incoming president of the AAO reached out. He is so enthusiastic, and he grabbed my hand and he said, guess what? I've been an Ortho-Tain customer for 40 years. So how about that? Even though he might not have used it in that direction, he understands the growth and development that we can create with these types of appliances. So the connections, the attention that we received is monumental. So guys, we're here. Hang in, enjoy, smile. This is what you became a dentist for. Change the world. You're all there. We all have to work together, but we will get it done.
Awesome. Thank you so much. So I'm actually going to take a few minutes because that's actually perfect. And I'm going to tell you guys a little bit about our Healthy Start digital education platform, because really it's all about that. I think that was probably what we heard the most during this meeting afterwards, is that how amazing it was, first of all, how wonderful it was to come together and bring this topic to the forefront. But the question left was, what next? You know, how do we start seeing these kids? How do we start addressing these kids? And so that's something that we help with. We have an education digital course that teaches everything that you need to know in reference to assessing. We also bring in your staff members. We want to teach your staff members about Airway and about what to look out for, and really just change your whole practice. So introducing the Healthy Start digital education course. We actually have a course that's starting really soon. It starts on September the 3rd. So it's coming up. The great thing that I love about this is that Leslie actually gives 2 cases with this course, because we really want you to have hands-on treatment. We want you to treat 2 children while you're going through this course, because that way we can kind of lead you through the entire process of these 2 kids. And so we're going to give you everything you need for the entire case for these kids from start to finish. So that includes the diagnosis, the appliances, animal cases. It includes marketing, promotion for your practice. It includes an app. We have a really cool compliance app for the kids that they feel successful. All of that comes with the course. There's a $3,000 voucher. Dr. Jill was talking about some of our destination courses. So we have a $3,000 voucher that we're going to actually hand over to you as well, that you can use if you'd like to attend one of our destination courses, and you can bring 4 of your staff members with. Every Friday, so the way that it works is on every Monday, we send out a digital class. So it comes via email. You have the whole entire week to watch it. It's in video format. So you have the entire week to watch the video. And then on Friday at 2 o'clock Central Time, we have an interactive study club. Everything is always recorded. So even if you can't make it on, we're going to make sure that you have everything in your hands. And these interactive study clubs are fantastic. Dr. Jill is actually agreed to be one of our mentors on the study club this course. So we're so excited to have her as one of our study club mentors. So she has she is a wealth of information. So anyway, it's amazing. Again, we always invite staff members to be involved, because we're not only going to talk about, for example, pediatric treatment of sleep disordered breathing, improper facial growth and development of dentition, screenings for sleep, breathing, and airway issue. We're also going to talk about increasing patient flow. And we're going to talk to your staff members about billing and about how to organize your office to see these kids. And it's just a really complete comprehensive course. So it's 18 CE credits and then 16 more when you come to one of our live courses as well. And this is a course that complements the new ADA policy on sleep-related breathing disorders. And really this policy states that it is the dental professional's responsibility to become educated on sleep and breathing issues. So as I mentioned, the course is fantastic, and we have tons of testimonies, and we actually have doctors from all over the world that attend this course. So a doctor from Australia attended, and he said that the digital course was excellent. All at Healthy Start have really got their act together and offer resources others strive for but rarely achieve. It's well organized, passionate, and supportive. Doctor from Canada says, I want to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course I have taken. And in Colorado, I've really enjoyed the course. We've identified quite a few patients that will benefit from Healthy Start. My business partner's 4-year-old is in the habit corrector because he has had swallowing problems, and we've already seen great improvement in his eating. We already have 3 more patients that will be starting next week. And that's really, you know, patients start lining up, parents start lining up, because once they understand what you're doing, next thing you know, they want their child to be seen. I was talking to a doctor actually in Chicago at the Airway Symposium, one of our providers, and she went through the last digital course, and she told me, she's like, oh my gosh, she said, I need more banners, I need more supplies, I need more everything. She said, I have parents lining up for exams. So anyway, it really is amazing when you start helping these kids. And ADA actually says that the Healthy Start digital education course is ingenious. And we actually have several ADA members that will be joining this course, which is very exciting. So how do you get started? There's a couple of different ways. The first is you can always, of course, call us at 844-KID-HEALTHY, or you can email at contact@thehealthystart.com. You can actually register tonight. We will actually send you a welcome package, and we're going to send you your starter appliances. Now, keep in mind, those habit correctors, you can get children started on them immediately. We do not need diagnostics for that. We're going to teach you, what to send in and all about, we're going to teach you all of those things. But initially, it's about getting those kids started to help them with their sleep and breathing issues. So you can get them started with those habit correctors, have them start sleeping in them at night. We're going to send those to you along with animal cases and everything you need for those kiddos to get started, and we'll send them to you immediately. It's a $3,400 investment, but because you were on the webinar this evening, you can actually go online to openairwaydentistry.com, click the Register Now button, and there's a little discount code field. And in that discount code area, if you put in the word Airway, it's going to give you $400 off of the course. So you can't lose. It's really ROI immediately, as you have those 2 cases that you can really, you actually start making money off of this course immediately, which is fantastic. Again, it's all about helping those kids. And as I say, now is the time. After spending this weekend at the Airway Summit, learning all of the things that you learn, understanding the issue that is out there. And as Leslie said, statistics show that over 40 million children nationally have sleep and breathing issues. So together we can make a difference. So I really hope that you join us. My email address is slafredo@thehealthystart.com. So of course you can always reach out to me, and I would be happy to answer any questions at all. The last thing I'll leave you with is, how do I get my CE credits? Basically, we will actually email you. I will send your name into the office, and we will email you your CE credit. But if you have any questions, this is the contact information. And I'm going to go back into the screen one more time, because if you screenshot this, then you'll have it, and you can do everything you need to do after the course is done. So Dr. Jill and Leslie, I want to say thank you so much for all of your input tonight. Dr. Jill, thank you for taking your time out this evening. I know that, this is such an important, children are so important, and I know that for Dr. Jill, this is such a big deal and big part of her life. So I want to say thank you to her, and Leslie as well. And I don't know if there's anything else that you'd like to add before we sign off.
I would just say, please, I know it was supposed to be more of an open forum. I know some of you are shy. You had called and said, I'll just type my questions, but please reach out, call us, tell us what you think, tell us, maybe things that you're struggling with. We're here to help you. We want to make this the most important treatment you offer in your practice. So whatever we need to do to help you get to that point, we're here to do it. So hopefully I speak for myself, hopefully I speak for Jill, and I speak for Susie as well. So that would be my message, and that would be my lasting thoughts to you.
I couldn't have said
Awesome.
it better, Leslie. Totally agree.
Well, listen,
Great.
have a great evening. Thank you for joining us. We will reach out to you if we have more. I would like to continue the discussion, make us a really powerful group that we can talk amongst ourselves, see what we need, even have that conversation with Steve Karstensen and the group to make March even bigger and better. So anyways, with that, good night. Have a great week. Start evaluating tomorrow. Let us know how many kids you have in your practice that need help.
Awesome. Thank you so much. Good night.